the post-traumatic stress disorder, PTSD, and the military. This is being presented by Dr. Shannon McCaslin, who is a clinical psychologist at the National Center for PTSD Dissemination and Training Division at the VA Palo Alto Healthcare System, and she is also assistant professor at the University of California, San Francisco. Her work is focused on providing outreach and services to veterans in the community, including the development of a VHA online toolkit for mental health providers in the community. So thank you, Dr. McCaslin, for getting up very early this morning to do this webinar for us. I would like to do some poll questions now. We do this at the beginning of every webinar to get an idea of who our audience is. So here's the first poll question. And I hope you all can see that. Yes, okay. Okay, we want to know what your current professional role is. Are you a counselor, therapist, social worker, counselor? Are you a nurse, nurse practitioner, perhaps a physician or physician assistant, a program or unit administration? Are you university student or faculty, or other? And if you'd like us to know what other is, you can put that in the chat or questions box, and we'll have that as part of the information that's kept for this webinar. Okay, thank you. I will close this poll now and share the results. In today's audience, 65% are counselors, 2% are either nurse, nurse practitioner, physician, or physician assistant, and 11% program or unit administration, 2% university student or faculty, and 20% other. Thank you. Okay, now we'll do the next one. Okay, what field do you represent? Are you mental health, addictions, physical health, education, or EAP? Okay, I think that's a good representation. Thank you. I will close this and we'll share the results. Okay, 46% are in mental health today, 43% in addictions, 2% physical health, 9% education, and we have no EAP people today. Thank you. These next two are going to be very quick. Do you currently conduct expert interventions yourself? This is just yes or no. Okay, great, thank you. I'll share those results. These get better every webinar. Let's see, 20% do currently, and 80% do not currently do expert interventions. Now, this is the last one. Does your agency use expert now, or will they? Do you see them using it in the future? And for anybody out there who doesn't know what expert is, it's screening, brief intervention, and referral to treatment. That's what it stands for. Okay, thank you. I will close and then share this last poll. 38% of the agencies either use expert now or will be using it in the future, and 62% say no. Thank you all very much for participating in those. And I will now turn this over to Dr. McCaslin.
All right. Let's see.
There we go. Thanks.
Thank you, Chris. Thank you, everybody, for joining us this morning. I hope you're all having a good morning. As Chris mentioned, I'll be talking about post-traumatic stress disorder, primarily with a focus on the military. And from the poll questions, it looks like we have a variety of individuals on the phone and probably a range of experiences with post-traumatic stress disorder. And so today I'm planning to give you, hold on one second, there we go. I'm planning to do a general overview of post-traumatic stress to give those who may not have as much of a sense of what the diagnosis is, to help them have a better understanding of that. I'll touch on prevalence and assessment for post-traumatic stress disorder, as well as some of the evidence-based treatments or treatments that have been recommended for use with PTSD. And what I'm very excited to share with you are a number of resources that you can use for a variety of purposes. There's resources for providers to assist with your practice in terms of assessment and training and CEUs and things like that. There's also a lot of resources that provide client handouts and client materials, and we'll go over all of those. I'll take a break for questions between talking about treatments and talking about resources. And if, by chance I can't answer your question on this webinar, I'll be sure to follow up with you following the webinar. So post-traumatic stress disorder was first recognized as a diagnosis in 1980. But that doesn't mean that it didn't exist before that, of course. So back to ancient Greece, people were recognizing the symptoms of PTSD and writing about them. Here in the United States, PTSD was known by different names. The core symptoms of PTSD were recognized and known by these different names, including shell shock, combat fatigue, soldier's heart, and rape trauma syndrome. And you may have heard of those names. But it wasn't really until the social context in the 70s where there was more attention to both rape trauma as well as the veterans returning from Vietnam that really drove the need to formally recognize the diagnosis in the DSM. Recently in 2013, the diagnosis was revised. Previously in DSM-4, it was somewhat different. The changes aren't very dramatic, but they are significant. And so I thought I'd go over the most recent diagnostic criteria for post-traumatic stress to give you a sense of what clusters of symptoms and what this diagnosis really looks like. Perhaps one of the biggest changes with the DSM-5 is that PTSD was taken out of the category of anxiety disorders and is now considered a trauma and stressor-related disorder. It also went from having 3 main symptom clusters to now having 4. There's also a greater emphasis on the nature of the trauma, so life threat, physical integrity, things like that, versus the responses at the time of trauma. So in DSM-4, there was a requirement that the person experienced fear, helplessness, or horror at the time of the event. However, that's been removed with this version and de-emphasized. So the clusters of symptoms, the first cluster is the re-experiencing symptoms. And this, the re-experiencing symptoms, the avoidance symptoms, and the arousal symptoms all existed in DSM-4. Those are not new clusters of symptoms. Number 3 that we'll talk about is the one that was added. But back to the re-experiencing symptoms, these include the things that you often think of when you think of post-traumatic stress. It's the memories that come up for somebody, either triggered or untriggered, but can be disruptive to them emotionally or physically. So for example, if you have a student veteran who's sitting in the classroom and trying to focus on what the professor is saying, and if the professor happens to bring up the topic of the conflicts in Iraq and Afghanistan, or says, makes even an offhand comment or describe something from those conflicts, it may trigger memories of their experience, which are very difficult for them to, they're not just passing comments for these individuals. It really can trigger a reaction emotionally and physically and make it very difficult for them to concentrate on what's going on in class, may cause them to actually walk out of class if it brings up enough emotion and enough of a reaction. And so very disruptive. And flashbacks as well are in this category. Flashbacks, formal flashbacks like you might see in the movies, are less common than some of these other symptoms. But they're, flashbacks can range, can sort of have a range. So you could have, something like you might see in the movies where a car backfires and somebody is thrown into fully feeling like they're back in a situation. Or you can also have experiences where people sort of know where they are, but they also feel like they're back in that situation. They're sort of straddling two worlds in a way and kind of feeling a little disconnected from what is going on around them. So the next cluster of symptoms is avoidance symptoms, and this actually was combined with the numbing symptoms in DSM-4, but now numbing has been moved down to this cluster 3. So avoidance stands alone, and avoidance is really the idea that somebody will avoid people, places, activities that will bring up these strong memories. And this can result in a lot of isolation, a lot of pulling back from things in an effort to avoid things that are going to be disruptive both physiologically and emotionally. The third cluster of symptoms are the negative alterations in cognition and mood. This is the new cluster of symptoms. And this has within it the numbing symptoms, which are feeling kind of detached or restricted range of affect. And there's a recognition that people with post-traumatic stress can experience a pervasive negative emotional state, not just fear-based, which many people think of with post-traumatic stress disorder. There's a new symptom that's focused on negative expectations about self, the others, and the future, and a new symptom focused on blame, either self-blame or blame of others. And the last symptom cluster is alterations in arousal and reactivity. In the DSM-4, these are the hyperarousal symptoms. And these include irritability and anger, sleep disturbance, the sense of always being on guard, really those hyperarousal symptoms. And they've added in a new symptom, reckless or self-destructive behavior as well. There's no change in the duration of symptoms, so you must have symptoms for a month. But they did eliminate a distinction between acute and chronic in this new version. So, we often now hear about post-traumatic stress with military and veterans, but, there are also many, many civilians who suffer from post-traumatic stress as well. And just starting with the prevalence of trauma, trauma is very common, actually, in our society. And at least half of men and women in the United States will experience at least one traumatic event in their lifetime. And we distinguish trauma often from life stressor, such as divorce or other things that can be very difficult for people by the presence of life threat or threat to physical integrity, those types of sort of core emotions. But it is very common. You can see there's some types of trauma exposure that are more common for men than for women and vice versa. For women, sexual assault, rape, molestation, abuse, neglect seem to occur more frequently. For men, combat occurs more frequently. And, a significant number, about a third, will experience more than one trauma in their lifetime. So there's a significant number of individuals who will experience trauma. However, that being said, most people do not develop post-traumatic stress disorder. It's not uncommon for people to have reactions immediately following a trauma because it's such a disruptive event. It's natural for people to experience some symptoms in the immediate aftermath or shortly after. But if the symptoms continue, then there's the development of post-traumatic stress or another disorder stemming from the trauma. And a minority really develop post-traumatic stress disorder, and this has led some people to call PTSD a disorder of recovery, that most people will recover, but that there's a subset that will go on to develop post-traumatic stress. In the general population, PTSD has been estimated to occur around, on an average, the average number that's thrown out there is usually about 6.8%, and you can see the slide on the right breaks down lifetime PTSD, so PTSD over the lifetime in the general population and current PTSD. And the rates of lifetime were higher, about 10% for women, about, again, 6.8% for the overall number, and lower for men at 4%. Current numbers were also smaller, so 5.2% for women, 3.6 overall, and 1.8 for men. And this is in the general population. So military service presents an opportunity for additional life stressors and traumas to arise, in particular combat trauma. And I'll talk a little bit about military sexual trauma as well as we move along. And I'm just, and some of you may be very familiar with military stress and trauma, and so I'll go over this fairly quickly, but just to mention, these are the types of traumas on this slide that, if you're in the civilian population, you may not be exposed to, and they can be, extremely traumatic, extremely difficult to handle, and many people experience more than one of these if they're serving in combat. So there's firefights, there's death, dying. There's also one thing that's not on here that can range from stressful to traumatic, is grief and loss, and losing a comrade or losing somebody who's you're serving with, depending on how that death occurs and how your relationship with the individual. In other military traumas, such as sexual assault, which I'll talk about, accidents that can happen during training or happen while serving, and physical assaults as well. Just getting a little bit more into combat exposure, just to note that when somebody returns from combat, that readjustment or separation from the military, transition to the civilian setting can be difficult for most individuals. But that brings up, there's unique stressors associated with that. There's separating from a cultural context that, can be very different from what you're returning to in the civilian setting. Including the structure, including the camaraderie that is so important and often so profound in combat service. Coming back to a family that's adjusted to you being deployed, and may, those roles may have changed in the family, and kind of figuring out where you fit now in the family and how, adjusting back to that. Work and skill adjustment, taking, what you've done in the military and being able to translate that into a work setting can be very stressful. So you may have been in a leadership position in the military. You may have had a lot of responsibility, and now your current job, it's hard to translate those skills into getting a job that's comparable. Again, grief and loss, dealing with those feelings and emotions can be difficult. And, there's also symptoms of PTSD that have a little bit of overlap with what skills somebody might need when they're serving in a war zone. So being on guard, being aware, being able to adjust to an erratic sleep schedule or be able to stay up at night and work during the day are all things that may be adaptive when you're in a combat setting, but can be disruptive when you're back in the civilian setting. And so it's not unusual to take some time to be able to adjust back to being back in the civilian setting. But a subset, as I had mentioned before, will find recovery more challenging. And these are the individuals that have both visible and invisible injuries. And post-traumatic stress has been put under that invisible injury category. For the returning veterans with the improvised explosive devices and the blast injuries that have been sort of a signature of these conflicts, from those blast injuries you can that can result in multiple things. So post-traumatic stress, mild traumatic brain injury, chronic pain, And so there can be a lot of different things going on for somebody. But post-traumatic stress should definitely be something that's assessed and looked at. So what is our best estimate of PTSD among the returning veterans, or OEF, Operation Enduring Freedom, Operation Iraqi Freedom, Operation New Dawn veterans? There's been a few studies that have come out that have provided us with estimates of PTSD in this group. One is the Invisible Wounds of War study, which you can find if you look up the RAND study and under that name, and you can read the full report. But this was a representative sample of men and women from all service branches, and they found a current PTSD prevalence of about 13.8%. So these are individuals who've been deployed. And studies suggest that approximately 15% of returning veterans will have PTSD. That's based on other estimates as well. When you look at some of the studies, they do say higher rates of PTSD among returning veterans. And just to note that some of the studies that show the higher rates are looking at a sample that are seeking care at the VA or seeking care in general. So those rates will be a little bit higher. So those rates have been shown to be almost 25%. Another study that's really fascinating is the Millennium cohort study. And this is a longitudinal cohort study of about 150,000 male and female military personnel. It began in 2001 and will continue on for a while. And it's really to look at the effects of deployment on these service members. So they assess PTSD at baseline, which is great. It's nice to have the opportunity to be able to look at people before deployment. And the rates are relatively low, so 2% in men, 3% in women. And when they followed up, they found that the rates were much higher later after deployment than for those who had not been deployed. So the rates deployed with combat were about 8.7%. And of course, the risk for PTSD will go up the more deployments that somebody has had. So our conclusion on prevalence of PTSD, you'll see that the rates vary across different studies and different populations, but generally we say 15% veterans of Iraq and Afghanistan and 6.8% in the general population will give you a general estimate. There have been rates that again have been found to be higher for treatment-seeking populations or just within hospital settings. I'm going to talk a little bit about military sexual trauma. This is defined by the VA as experiences of sexual assault or repeated threatening acts of sexual harassment. It has gotten more attention recently and for the need to both recognize and to treat MST. Some of the prevalence estimates that have been thrown out are have been studied, 20 to 30% of female veterans enrolled in VA, and 14% of returning veterans are enrolled in VA who are female. These rates are much lower for men, 1 to 10% of male veterans and 1% of OEF veterans. Again, for both groups, there may be some reporting issues around stigma and that kind of thing. For men in particular, it may be very hard to come forward with these reports. Because the numbers of male veterans are so much higher, when you look at the actual numbers of people reporting this, the numbers are both very, very high. But proportionally, the women report more MST. These estimates are based on assessments that were conducted in primary care mental health when veterans first seek care in VA. And down here I have the screening question that is asked for military sexual trauma within VA. All veterans who screen positive for military sexual trauma are provided with free health and mental health treatment for related issues within VA. That's an important thing to know. If you're seeing somebody and that comes up as an issue, you can refer, and those issues are covered. Similarly, for OEF veterans, if they have separated within the past 5 years, the VA, or for the first 5 years after separation, the VA does provide free health coverage for them. And so it's a nice time for them to get into care and get assigned a primary care doctor and have that as, even if they have other health insurance, it's a nice backup to have in case they need services. Veterans with military sexual trauma are more likely to be diagnosed with PTSD than combat veterans, actually, and female veterans are 3 times more likely to be diagnosed with PTSD than their male counterparts in general. So the clinical assessment of PTSD can range from very simple screening to a very lengthy clinical interview. And when you're seeing people for other conditions, it's never a bad idea to screen and just see, is this an issue that we should address or I should refer out for? There's measures that exist that are approximately 4 to 5 items long that you can use for screening. One of them is the PTSD, and I'll show you where you can find these measures and find more information about them. Often we use self-report measures. One that we commonly use is the PTSD checklist, and that's a brief measure, but it goes through all the symptoms and allows you to get a sense of what the person is dealing with. If they do screen positive, they should be more thoroughly assessed, of course, and there are diagnostic assessments that are validated. One that's commonly used is the clinician assessment for PTSD. It's the CAPS interview, and that's available, I believe available for DSM-5, or if it's not right now, it should be shortly. And the link down below will take you to a professional section of the National Center for PTSD's website where you can find all of these assessments listed, information about them, scoring information, how to get them. And so I suggest going through that and looking that over to see if there's something that might fit into your practice or what you're doing that you could use. Again, it's always important to assess for comorbid disorders or problems. And some of the common things that come up for individuals with PTSD are substance use. Some studies have shown about 20% comorbidity there, depression, anger issues, and different things that may impact what you do in your treatment with them. So there have been, the VA Department of Defense put together the clinical practice guidelines in 2010, and if you go to this website I've listed here, there's actually a short course that I believe offers CEUs where you can learn more about the clinical practice guidelines, and it actually takes you right through them and gives you the highlights. I'm just going to briefly mention what came out of this report that was done in 2010. If you go to the website for the clinical practice guidelines, they will share with you some of the changes that have been made in terms of updates. There have been, for example, medications that have come out with new warnings and things like that that they'll that are up on the site. But really, the guidelines looked at 3 main approaches to treatment. So therapy, medications, and other problem-focused services. And they looked at the evidence for use within, for those with PTSD, use for these different modalities. And one thing that really seemed to come out of this was that there was a very strong recommendation for evidence-based trauma-focused therapies. That these really kind of came out on top in the guidelines. And these include prolonged exposure therapy that really have a focus on the trauma, cognitive processing therapy, which focuses both on the trauma as well as a very strong component of cognitive restructuring, and EMDR. And I'm just going to show you, so these are the tables that are in the guidelines. And along the left are the recommendations. So an A is a very strong recommendation that there's a lot of evidence suggesting that these are helpful and they're recommended. A C is that there's fair evidence that there may be times where it's warranted and times where it's not. And the last section is that there's really not enough evidence, that there's more that's needed, but that in some cases it may be warranted, but there really is a call for more evidence needed in these. And so it's not as strongly recommended. So you can see again the significant benefit really stands for the trauma-focused psychotherapy, including components of the exposure, cognitive restructuring. Stress inoculation training also made it on that list. And then you can see in the column of some benefit with some evidence are a list of other things that may be used for PTSD. In the unknown benefit category, there's some very promising things that are in that box, actually. Web-based CBT, we just are in the process of looking at how helpful that might be for people. In the National Center for PTSD, we are working a lot on the development of technology to be able to deliver CBT via the web or provide CBT support through mobile applications. And I'll show you where you can actually find some of these products. And but the studies are really underway currently to test just how helpful these things are. ACT, Acceptance and Commitment Therapy, and DBT, Dialectical Behavior Therapy, are both evidence-based treatments for depression and borderline personality disorder, respectively. And those are also being studied in PTSD, and I think we may see more on them in the future. These are some of the medications that they looked at for PTSD under the clinical practice guidelines. You can see, again, there were not a ton that came up in that very strong recommendation box. SSRIs and SNRIs. There were some with some benefit, for example, Prazosin for sleep or nightmares. And then a significant number that they found there was no benefit and no reason to really use those. And again, any questions about this, feel free to refer to the guidelines or to take the brief course that I linked to in the slides that can give you more background on this and more information about the evidence that was looked at. Okay, at this point I'm going to take a break for questions, and then I'll move on to resources. I definitely do want to spend some time on the resources because I think that is key to being able to find what you need and what will fit for your work and what you do. So yeah, thank you.
Okay, I do have a couple questions here, and I do have a hand raised. So we're going to see if he really meant it or if this was just a mistake. Hold on just a moment. Mark, I see that this is Mark Johnson. Would you like to speak to the presenter? I unmuted you.
Oh, no.
Okay, thanks.
Oh, okay, Mark.
Yeah, forget that. We'll take off his little hand. Okay, I have some questions that have come in. In what setting are most vets with PTSD served? And what are the needs that remain unmet?
Oh, that is a great question and a very large question. And I'm not sure I actually have a solid answer to that because, we know that not all veterans will seek care in the VA. I believe it's about, one study I think showed about 50%. And if that number isn't absolutely correct, I will let you know afterwards. But, we know at least half probably are not going to seek care at the VA hospital. And so there's a great need for people to be served in the community and for community providers to be able to work with VA to be able to serve veterans and for veterans to also know where to seek care in the community. I'll look into it for you. I'm not aware of any studies that show, the exact number of veterans where exactly they're getting their care. That would take a large kind of prevalent study about, asking individuals where they are actually seeking most of their care. But we know that a significant number will actually seek services outside the VA hospital. And so it is extremely important for providers to be able to communicate with VA and be able to use whatever resources exist. I don't know if that answers your question.
Here's another one. Ooh, they keep coming in here. Is anyone researching if returning vets are having problems accessing services?
There are. I'm not, again, I will look into that for you in terms of current studies going on. There are a number of researchers that look at service provision and, how care within VA and people seeking care within VA and different barriers to services things like that. And so, I'm fairly certain that there are studies going on, but I'm not sure which, I don't have one to refer you to at the moment. Chris, some of these questions, will you forward these to me later so I can answer them?
Sure.
Get them the information? Great, thank you.
Yeah. I would like to get training in evidence-based treatments for PTSD. I'm currently practicing in mental health with the LICSW. Do you have any recommendations? Do you know of any like online programs, or do you have trainers throughout the country that can be called upon?
So I do have some resources to refer you to, and some of those will come up in my slides. One slide that I realized I didn't put in here was for the Center for Deployment Psychology. And they actually they have an online training, I believe, for, could be cognitive processing therapy. They also have some military culture trainings. I would check their site. It's Center for Deployment Psychology. Also, I'll show you a website where there are some online courses about the evidence-based treatments and things like that. Center for Deployment Psychology, too, I believe will come out and do some trainings in cognitive processing therapy, for example, if your agency requests it. Again, I would check their site, but I'll also show you a few resources where you can take some online courses on the evidence-based treatments and learn a little bit more about them.
Okay. Let's see here. A couple of people are asking about getting the PowerPoints. Later today or first thing when you get into work, either tomorrow or Monday, you'll get an email from me that will give you the link to the PowerPoints that you can download. Also, the link will be to the recorded webinar. So everybody who's attending will get those. What is the most common substance abuse diagnosis for returning vets with PTSD?
So I actually don't have that in front of me. I think, I would say probably alcohol use is quite high in terms of comorbidity within SUD, within substance use. And again, I'm going to refer you to a guideline that has recently been put out for substance use and PTSD comorbidity. I'll show you where that is, and then I'll give you a lot more information about both the comorbidity of substance use and post-traumatic stress disorder, as well as where you can, or which treatments are suggested for use for the comorbid conditions. And I think that'll be very helpful. And that I'll make sure that I give you that information.
Okay. Yeah, and that was actually the next question, so you took care of both of those. We'll do like one more right now, and then we'll get to the other ones later. I don't want you to interrupt your presentation here for too long. Pharmaceuticals are not tested on people who have traumatic brain injuries. Is there any information available regarding harmful side effects when, for example, SSRIs are given to veterans with comorbid PTSD and TBI, especially leading to suicidal ideation?
Okay, that is a very good question. And again, TBI is not, and especially medication or prescriptions for TBI, I'm not as familiar with, but I will definitely look into that for you. Yeah, and I'm happy to get you that answer.
Okay, there's a lot more, but why don't you go on, and then we'll try to answer whatever we can at the end.
Sounds good. Thank you, Chris.
Thank you.
Okay, and again, I apologize if I can't answer your question exactly at this moment, but I will definitely get back to you. All right, so let me see. For some reason, Chris, my slide isn't moved. Oh, there we go. Perfect. So I'm going to go over some VA resources, and actually this is a little bit misleading, so I'm also going to give you some resources that are not VA that I think can just be very, very, very helpful to draw on, and so I'm excited to share them with you. The first one I'm going to tell you about is the Community Provider Toolkit, And this was something that I was very involved in here at the National Center, and we worked a lot with VA and national experts on, and also worked with experts at SAMHSA to figure out what would be most useful for practitioners in the community who will be seeing service members and veterans. What from the VA would they maybe appreciate having in their practice? What education might they want? And so really focused on being a very pragmatic website that gives useful information. There's not intended to be a lot of text within the website, but really pointing at resources and tools that people can use. It has, let me actually just see if I can take you through this very quickly. So this, can you all see the website here? Is it, Chris, do you see that?
Yes, thanks.
Okay, so up on top, this is screening for military experience. We know that many people actually out in the community don't ask the question if their patients or clients have ever served in the military, which, you know, can open up a whole world of benefits for people and different resources. And can also just be a very important part of their identity. And so we encourage always screening. And so there's a section on that. There's a military culture section, so understanding the military experience, information about the various aspects of military culture, not just the logistics of military structure, but also sort of the values and the beliefs and things like that. And then the other section that I'd like to show you is the mental health and wellness section. So these are what we call mini clinics. Just as an aside, the VA is very, everything that we do is focused on the recovery model or embedded within the recovery model, and so there's a button on the right that you can learn more about that. Each mini clinic down here at the bottom provides some resources and tools for people to use with their patients. They're structured fairly similarly across the mini clinics, and we're constantly adding to these. So right now in the works, we have a family mini clinic in the works with resources for family members and parenting, things like that. Just to take you quickly into the PTSD mini clinic, you can see this one is, you know, the first page is basics, and then there's a page on assessment where you find the screening, where you find information about more tools. So this is the PC-PTSD screen that I mentioned, and that's currently being updated for DSM-5, and once that's available, the new version, I'll be posting that on this website, where you can find some downloadable patient handouts for patients. Treatment and training, this is for the question that was about where can I learn more about where I can get trained. This has a number of different sources for training. So actually the link for Center for Deployment Psychology is embedded within this page. And so you can learn more about both the pharmacological treatments as well as the psychotherapy treatments, clinical practices, things like that. The PTSD, professional PTSD consultation program, clinicians can call in to the consultation program through the VA to ask questions about PTSD, general questions about PTSD, referrals to VA for PTSD care. I believe that they can't give specific feedback on a specific patient, but if you have general questions related to PTSD, they're happy to consult on that. Once you consider referring and how do you refer to VA, online resources that can be very helpful. And then at for each mini clinic, we finish with what we call a cool tool. So something that's come out recently that might be something you can give to your patient, like this mobile application called PTSD Coach, or new materials that just will be useful for practice. I'm going to show you quickly the substance use one, because this is where you would find the substance use guidelines, the PTSD and substance use guidelines. So again, there's assessment, and this will drop down different screenings and different things for assessing substance use and drug use. There's client educational materials, again, very structured very similarly across the mini clinics. And then here, under treatment and training for substance use is where you'll find the VA guidelines. And there's comorbid substance use and PTSD there. Okay, again, referring online resources there, and the cool tools, My Healthy Vet. If you do have questions or want to connect with the VA around either, you know, referring somebody or just working with VA referring to specialty services, or for continuity of care if you need medical records, that kind of thing. The Connecting with VA will give you information on those types of issues. Okay, I'm going to go back. I'm realizing we're a little low on time, so I'm going to kind of speed through some of the next slides. Again, this is just what you got to see live. The National Center for PTSD website is just a goldmine of information on PTSD. It has, an overwhelming amount of information actually sometimes. But there is a search function. You can search for what you need. There's a public section that you can refer clients and patients to for the general public. And there's a professional section that will give you information on assessments, treatments. Again, there's many continuing education courses on the National Center for PTSD that are free, where you can learn more about these various aspects of post-traumatic stress and assessment and different things like that. AboutFace is a campaign that the National Center for PTSD has recently started. And I would go on their website. You can find AboutFace on the National Center's website. And this is stories from veterans about their experiences with post-traumatic stress, their experiences with treatment, what helps them. And these are real stories from real veterans. And there's a ton of them up there. And you can use them for talks that you do. You can use them just to learn more. Sometimes for patients, it can be validating to hear the stories from other veterans. So online education, again, there's just a lot of information on the National Center website. I just suggest taking some time to explore that. They have handouts that you can give to patients and clients again. This is the crisis information. We do have a suicide prevention mini clinic within the Community Provider Toolkit that will list all the different resources and options for suicide prevention as well. But the National Center gives you a brief kind of synopsis of the veterans, what to do when you're in a crisis. So the Veterans Crisis Line is available for veterans to call 24/7, and that number is a good thing. If you go on the Suicide Prevention Mini Clinic, there is you can order materials or download materials to give to patients or veterans. The PILOTS database is embedded within the National Center for PTSD website. This database is not unlike PubMed or PsycInfo or different citation databases that are out there, except for the fact that it's completely focused on PTSD. So pretty much any reference or any citation you might need should be in the PILOTS database around trauma. So if you have a specific question that you're looking for an answer to, this is a great place to be able to find the literature that's come out on that topic. I also suggest looking at afterdeployment.org. This is just a great website. They have a provider section and a public-facing section for the general public. So this, what I'm showing here, is it's for the public, for veterans, for service members, for family. And they have different workshops and different topics that people can take to learn more. It includes assessment and sort of understanding where they're at with things, where to get help, and provides a lot of psychoeducation. The provider tab, if you go up, there's a provider tab in the corner left on this website, and that they also have they nicely list all the clinical practice guidelines that have come out for different things, and also list the mobile applications, smartphone applications that have recently come out. Make the Connection website is also a VA national campaign that's it's very similar to AboutFace, except that it's across a range of issues, so including substance use and other problems or concerns that can come up. And veterans can actually filter this by their era, by their gender, by whatever these different aspects that you can see. They can customize the site to find the stories that most resonate for them and hear what other veterans have done. Military One Source, again, is a good source for service members from branches, family members, service providers. There's a lot of information and support there. The Defense Center of Excellence Outreach Center, again, support information. It's a good place to go for people. I'm going to go over the PTSD Coach Phone App. Since this talk is on PTSD, I'll mention this phone app, which is, really for those veterans and service members who have a smartphone. This can be a nice tool to have on their phone. They can assess their symptoms. They can develop a self-management plan. When they need to, they can find a tool on the smartphone that might be able to help them manage their symptoms in the moment. So you can see here's the assessment. They can track their symptoms over time and share this with their provider by bringing it in. It gives them, what's wrong, what's going on for you, and will give them options to cope. These apps are always being updated, and so the screens may not look exactly like what I'm showing you today because they're always being changed and improved. But these are the general components. So these are some of the tools that are on the phone. And these are some of the apps that actually are released or are going to be released soon. There's the TBI coaches that released. It's a self-management for TBI, and it's actually called Concussion Coach. This is an older image, but it's Concussion Coach. You can find these in the iTunes store. Some of the newer apps are not on Android yet, but many of them are. There's a distinction between the self-management apps and the apps that are intended to be used with a provider in treatment. So the PE Coach app, the CPT Coach app, and the CBTI Coach app, CBT for insomnia, are intended to be used with a provider in treatment. Whereas Mindfulness Coach, Concussion Coach, PTSD Family Coach, and PTSD Coach can be used for self-management. And you can find all of the apps in the description at the link that's above the slide, or on the slide. So again, where to get help if veterans don't know where to get treatment, or they want to connect with VA, or they want to just get some help in the moment, or they're having a crisis, they need to talk to someone. There are these resources available. And again, I already showed you the connecting with VA piece of this, and this is where, if you want more information on how to actually connect with VA, be able to get release forms for patients you're seeing, things like that, this is where you might find that information. There is also an OND clinic within the VAs, and this is their webpage, and it can give people a good overview of the benefits that are available to these returning veterans. That's their site. So that's it. I really appreciate you taking the time to listen. And again, if I don't have an immediate answer to your question, I will try to get back to you as soon as possible with an answer. This is my email, so if thoughts come to you later or questions, feel free to shoot me an email, and I'll be happy to answer those.
That's wonderful. It's just loaded with references, and I think that and resources that everybody will certainly be able to take advantage of. So that's really great. There's a ton of questions here, but we are, basically out of time at this point. I will assure everybody that I will forward all these questions to Dr. McCaslin, and if people look in their questions box, I did answer one person's question with information that you'll be getting from me later. I will, once I get the replies to the questions, they will go into our webinar library along with this recorded session and the downloadable slides, as well as the resource information that was sent to me separately. So I think rather than trying to get through all these other questions, at this point we can close this webinar, and please look for my email later today. I think that'll be it. Thank you very much, everybody, for joining us. Look for my email with the links to all this information. And again, thank you very much, Dr. McCaslin, for getting up so early in the morning to do this webinar. We sincerely appreciate it.
It was a pleasure. Thank you so much.
Sure. So at this point, what I'd like to do is just give people a brief tour of our website. And this is more for screening, brief intervention, and referral to treatment. But I think I'll get out of all my other things here. I think that it will be beneficial for you to see what the ATTCs do and how they can help you with a lot of resource information in addition to the PTSD information. We are the national SBIRT ATTC. And what SBIRT is screening, brief intervention, and referral to treatment. And it's a screening that can take place in physicians' offices, in emergency rooms, in any clinics and dental offices. And it's just a brief screen to check out people's, if they have any issues with drinking or drugs that might be a reason for some of the complaints they have when they come into the doctor's office. So this is our website. We're part of a national ATTC network, and it would be great for everybody to find the ATTCs in their area and to link with them to get a lot of information on addiction. So we have this map, and I'll give you the link to all this in the email. Here's a map of the United States, and there's an ATTC for each region. You would just click on that region. This is Pacific Southwest, and you'll see theirs. And you'll see their specific topics that they have. You can contact them. You can see all their products and resources. These places also have a lot of their own online trainings and their own topics that they are interested in moving forward. This is the one for the Midwest. Now, in addition to that, there are 4 general topic areas that are in a national focus. There's a frontier and rural ATTC. There's one that deals in American Indian and Alaska Native. And then there's another national Hispanic and Latino, and that's in addition to ours. We have brief little tiny webinars that will go over some products. This one we have now is about rethinking drinking, and you can also link to that. Also, if you're interested in to see what trainings we have available, we have the calendar, and you can click on any of these for more information and then a link to registration. Also, somebody was asking about trainers. If you want to see who the trainers are in your area, and these are recommended by your regional ATTC, just either click on your state or a name if you know it, or just click on the region, and you will see the listings for the trainers in your area. And really, even by clicking on these, you can see what other courses they can train on besides SBIRT. And you will see PTSD in some of those as well. So this is a good list of where you can find trainers. Now, we also have a suite of services, the trainers, the webinars. You know, we have the webinar library and other items available. There's our e-newsletter is called the SBIRT Alert, and you can subscribe to that here. We also have the IRETA Current, which is more general addiction topics. IRETA is the Institute for Research, Education, and Training in Addictions, and that's where the National SBIRT ATTC is housed, and we're in Pittsburgh. So there's our partners, which is NORC at the University of Chicago, and they also have a lot of great webinars and their own webinar library. So that's another place to look, and you can link to that from here. Now, we have distance learning. We have a few online courses that you can take. And our e-news, again, the SBIRT Alert, you can look at the most current issue right here and get an idea of what's available. And you can also get information on our blog and a lot of other items we have for you. There's a way to connect with us here in Pittsburgh. So we have a lot of good information here, and I think it will be beneficial for you to check us out and also to check out the other ATTCs in your area, because they will give you a lot of good resource information. So at this point, I will close the webinar to everybody. Be assured that questions will be answered and put in our webinar library along with all the other information that you've gotten today. So thank you very much. Please go to our ireta.org webinars to see what other sessions we have coming up in the future. Bye, everybody.